Hello, everyone. My name is Dr. Sarah Hallberg, one of the medical directors here at Virta Health. Welcome to our first day of Beyond Telemedicine. Thank you to Bill for kicking us off and excited to jump into our first full session with everyone. In just a minute, I'll introduce speakers for a panel discussion on the most talked about topic in the news this year. 2020 will forever be remembered by the COVID pandemic. Almost immediately, the global health crisis brought in-person healthcare to a stop in most cases. Both providers and patients had to quickly readjust to a new system based almost exclusively on virtual visits. The genie is out of the bottle, and it's clear that virtual care is here to stay. Now, the question is, how can we seize the moment? How can we use the gains from the last 6 months to create better healthcare going forward? Our goal should be not just convenient healthcare and more access to healthcare, but we really want to improve the system overall. First, we'll hear from Eric Hargan, Deputy Secretary of the U.S. Department of Health and Human Services, on his vision for the future of virtual care. From there, we'll move on to providers and those leading major provider groups, including Dan Schellenbarger, partner at Oliver Wyman, Robin Glass, president of Doctor on Demand, Dr. Andrew Diamond, Chief Medical Officer of One Medical, Dr. Peter Rasmussen, Medical Director of Digital Health at the Cleveland Clinic. Next, we'll start the discussion with health plan leaders on how they're addressing the rise in virtual care with Dr. Rahul Rajkumar, Senior Vice President and Chief Medical Officer at Blue Cross North Carolina, Dr. Patrick Conway, Chief Executive Officer, Care Solutions at Optum United Health. Then we'll hear from employers and those who work most closely to design benefits for large employers on how they're thinking about benefit offerings amid the pandemic. Speakers include Hassan Azar, Senior Vice President, Total Rewards at JLL, Larry Hansard, Director of Healthcare Practice at Gallagher, Rob Brinkerhoff, National Managing Director of Healthcare Practice at Gallagher, Aaron Tatar, Senior Vice President at Fidelity Investments, Steve Martin, former CEO of Blue Cross Blue Shield of Nebraska. Lastly, we'll close out with Kelly Close, the founder of Diatribe, to share how the diabetes patient community is feeling about the explosion of virtual care. Thanks for joining. We hope you enjoy the session. Provider perspective, using virtual care to address gaps during the COVID-19 pandemic. What is your vision for virtual care? What changes are you most looking forward to?
Yeah, I think that what we've seen, and I think everyone's seen this, is the explosion of telehealth and telemedicine over the last few months. It's been one of the, I think, very rare silver linings of this coronavirus outbreak, and then our ability to put together a package of regulatory relief that enabled a lot of the, explosion of telehealth coverage, reimbursement, and access all at the same time. So, for example, our head of our CMS, which is Medicare and Medicaid, put in place a lot of changes to the reimbursement for telehealth and telemedicine and expanded some of the ability for it to come outside of the restricted rural environment that it was in and to pay for more things. That obviously increased the ability of providers and patients to access that. At the same time, our Office for Civil Rights, which oversees HIPAA, made some crucial changes to this to enable telemedicine to be conducted over regular programs like FaceTime and Skype. Also, our Office for Inspector General made sure that some of the waivers and payments would not be prosecuted by us, which was also necessary. So we had three agencies that kind of cooperated on a big bang of regulatory reform early on in the outbreak that enabled, I think, from our point of view, the expansion of telehealth and telemedicine. So we went really from about 14,000 beneficiaries at the first week of March to now over 10 million from our point of view. The visits skyrocketed. I think every provider has the same kind of story of, now in many cases, thousands, tens of thousands of telehealth visits taking place, and really within a really short period of time, March to April, when you really see an exponential growth, and it has just continued. Now, it's leveled off somewhat, but it's leveled off at a much higher place than we were before. So I think that it is now at this point, it has become a permanent part of American medicine. And so I think that this is going to be a very exciting time the next 3 to 5 years as we work on expanding this and finding where telehealth works and telemedicine works and other things like remote patient monitoring and some of the other things that kind of go around telehealth and telemedicine. Sometimes people think of it just as, something where you kind of have your phone or you have a screen, you talk to a doctor somewhere else, or a doctor talks to another doctor. I think it's far beyond that. I think it's an issue of how patients can be empowered to care for themselves in some cases, and where they can get access to healthcare services and more sophisticated healthcare services than they ever could before. So I think there's a whole panoply of options that are going to open up for patients and for providers in the near future. And you asked a question about 3 to 5 years. I think between the interaction between this, the interoperability rule, which we put out in March of this year, which is calling for patients to get a longitudinal health record from all different sources in one place, I think that's going to have changes that I think are very complementary to the changes that are working elsewhere. I mean, I think that while we have made leaps and bounds in terms of how we deal with these things, but issues now, remote patient monitoring and some of these wearables or implantable technologies and other things that monitor patients more continuously also raise the issue of how we deal with the information that's generated by these devices. So, for example, no team of clinicians, no matter how dedicated, no matter how intelligent, is going to be able to keep up with thousands of patients generating streams of information 24/7 from devices. That is going to require us to move to possibly using much more artificial intelligence, machine learning, other kinds of more sophisticated analyses that detect trends in the information that's coming from the patients. The question is going to be whether a provider or a company that's bringing in AI or bringing in much more virtual aspect to health, where they see their mission going and where they see these technologies in terms of their business model. I've had some provider systems that have been very frank about the fact that because we don't pay for virtual technology, everything is costly to them. They spend the time to build out these expensive systems, and then they essentially obviate a lot of the services that they're providing in their system. They really want us to move to a much more value-based care setting. When we pay for each service, we're not really going to end up paying for each and every virtual service. That would probably bankrupt the fisc very quickly. If we move to a value-based care system in which we pay overall for value that's produced in the system, I think that technological solutions will be at the forefront of enabling American medicine to get value and a much higher degree of value for patients and everyone out of the system. So I look forward to that as we kind of move out of the older system, the fee-for-service system that we have right now, into a new world of more and more value-based care. I think more technological solutions, more telemedicine, more remote patient monitoring, more use of artificial intelligence and other augmentations and supplements to clinical care will be, I think, easily and much richer. It'll be easier to bring them in. It'll be a much richer approach to American medicine when this all settles out.
As a company already offering virtual care prior to the pandemic, how has your strategy shifted at Doctor On Demand over the last 6 months?
Yeah, I mean, it is amazing. I can picture myself in our boardroom in February of this year and our board members saying, if there's something you could be doing on COVID, instead of being in this room, I want you to leave now and go do it. And so we set up a war room back at the end of February because we saw that this was something that was very likely going to hit the US and hit the US very hard. And it did. And those first few weeks were really challenging because needless to say, nobody staffs for a pandemic. So we just saw this incredible onslaught of demand for our services and had to respond very, very quickly to address that. And luckily at Doctor On Demand, we have an employed physician model. So we were able to go out to our highly engaged physicians and say, we need you to take on extra shifts. We need you to tell your friends about us, and we need to bring more physicians onto the platform as fast as we possibly can. We were really lucky that our technology platform hung in there. We had to increase the bandwidth of it by, I think, 3x in a very, very short period of time to be sure that that would be the case. And we ultimately hired hundreds of additional physicians and behavioral health specialists as well. So it was just a completely intense time. It felt like a tidal wave. And, I used the word earlier, exhilarating. It really was, because it was kind of like we all rallied around this common cause and got the chance to innovate at a pace that you just don't usually get to do. You realize in those moments the way you internalize barriers. And this was one of those moments where you could strip all that away and just do what needed to be done in order to serve patients. And so ultimately that was, a really gratifying process. But needless to say, those first few weeks, we were working nights and days and weekends, and there was a lot to be done.
How did Doctor On Demand respond to the increased demand for virtual care during the pandemic?
One of the things that we first did was to build a risk assessment tool right on our site. And this tool at first was, highly focused on just educating the population. But as the volumes kept going up and up and up, it also created this opportunity for us to triage people to the level of care and sort of like get the people who needed it most to the front of the line to get care. And that was actually a pretty neat moment for us as a company, because when you're in our business, you're constantly trying to get people to try telehealth, and this was a moment where we were needing to think about it a little bit differently of who needs the care most and what type of care do they need. And I think that that's actually a great framework for thinking about things like value-based care in the future, and really having a smart way of intaking patients and getting them to the right place in care. Another thing that we did is we started kind of educating patient populations all at once. So we offered a series of clinical webinars with our clinical leadership team where patients could sign up, and hundreds of them sat through one session where they learned all about the coronavirus, about the symptoms, about treatment, and all of that, and had the chance to ask their personal questions, via chat for this broader group. And, there's been a lot of work done on both the efficiency and effectiveness of educating patients in a group setting, and we got tremendous feedback from it. So that was another really important part of how we responded in those very early weeks. And then I think lastly, I would just say we were really lucky that we had our behavioral health practice up and going already. And we quickly realized that this was not only going to be a medical crisis, but also a mental health crisis. And so just as quickly as we started recruiting more medical professionals, we also were adding to our behavioral health practice and doing things to kind of help people to find both of those services within our platform. And the demand on that side, unfortunately, in some respects, has continued to just increase over time. So we are definitely working hard to address both aspects of the coronavirus pandemic.
How are you shifting One Medical's in-person primary care model in response to the increasing demand for virtual care?
Well, that's a really fantastic question, and one that we've been thinking about for a decade plus, but of course much more intensely in the COVID era. So prior to COVID, our providers would take care of patients in the office, and we had a dedicated virtual medical team that would handle more on-demand needs when the offices were closed, on weekends, when the primary care providers were busy with seeing patients and somebody called in from home with a question. There was a separate medical team handling all of that inbound need. But also, the primary care providers themselves, perhaps in between visits or at the end of the day, would also do what we would now consider virtual care, messaging asynchronously with patients, getting back to patients about their lab tests. So there's always been an element of virtual care in our primary care model. But with the onset of the pandemic, we immediately had to add another mode of care, which was for our primary care providers in offices to instead do what we are calling remote visits, so scheduled appointments with patients on their panels to take care of those patients via video or by telemedicine. So now what we're seeing is really a continuum of options from in-person care with your primary to in-person care in a more urgent care-like model with the next person available, to virtual care with your primary care provider, to virtual care with someone else, or maybe just video chat, asynchronous communication, like messaging, and even pure self-service entirely over the app. So having that entire continuum available gives our members a huge variety of options, and we can help guide them towards the option that's going to get them the most efficient, the most high quality care in the way that meets their needs.
What are the biggest challenges in creating better virtual care offerings going forward?
Well, what I think would be most important for the future of virtual care would be to achieve the right level of continuity across all the modes of care that are available now, including virtual care, but also including in-person care, hospital care, specialty care, and on and on. Right now, I think it's far too fragmented. When I think about current models of virtual care that are more transactional, where it's not easy to predict who you might be seeing, and it's likely to be a different person each time. In primary care, where so much of what we are trying to assess isn't just a lab result or an image or a tracing from a machine, but rather a patient's demeanor, how they look, how they sound, how they carry themselves, how worried they are about a particular new symptom or set of symptoms. The only way to really genuinely compare that to the past is to have your own mental model from last time. So you're in such a much better position to make an accurate call in terms of what you think the diagnosis might be or the differential diagnosis might be if you yourself saw that patient before. That's why having continuity of care is so important. And I hope that as we continue to see virtual care grow, that we are attentive to the need for continuity through the virtual care platform.
How has the pandemic impacted providers and traditional health systems? How can they prepare to succeed going forward?
So the first part of your question around the impact, of course, has been severe. The suspension of elective surgeries, the sheer withholding stopping the seeking of care that the population had. Those two things in tandem, I think, had a very substantial impact. The other part of it is when you think about hospital systems make the majority of their profits on commercially insured populations, which again kind of receded as the furloughs set in and as unemployment set in. The repercussion is, of course, that the commercially insured population will decline, and by our estimates, that decline in uninsured population for every click up of unemployment by 1%, there could be anywhere from a 3 to 10% decline in provider revenue. That varies based on payer mix and the marketplace where you are, but you get the point. There's a very substantial correlation between unemployment and provider revenues. So now that brings us to the second part. If you believe you're going to have substantial unemployment, well, then you need to set a pretty substantial cost target. And I think from our point of view, what we're starting to see kind of the more progressive providers embrace is this notion of I can no longer benchmark and just benchmark and cut. There's just not enough headcount left necessarily, and that's not an effective way to run my business. And so we've been working with a couple of systems where we've effectively redesigned their way of thinking about expenses, and not thinking about them as expenses, but really thinking about them as investments in their business. So I think the fundamental shift that I think we're hoping that we'll see as perhaps a positive byproduct of this experience is that we'll see providers embrace their expense and their budget as an investment, right? And really rethink how you go to market with different services, what services you can and should offer. And by virtue of doing that, write the cost equation with that revenue equation in a way that allows them to be sustainable.
How have health systems leveraged telehealth to manage the surge in visits due to COVID-19?
Yeah, I think, it was fascinating. This is from the early days, but as we were all kind of preparing for the initial, what I'll call the initial wave, I guess, to mark time with that, I would say the March and April time period. From our vantage point, providers were all kind of turning and almost, going to battle stations, if you will. And, and so as it relates to how did they use telehealth and telemedicine in the surge, I think what we saw is the opportunity for systems to really use these as extending, capabilities. And so what I mean by that is obviously there's the triaging function that I spoke about just a minute ago, where by virtue of pushing forward telehealth as a means of interacting with your provider, you're now able to, not endanger yourself, not, leave the house, but yet get the care that you need, or at least get a meaningful portion of the care that you need. However, I think we've also saw organizations, plan and prepare to use it in ways that allow them to extend their staff. And so what I mean by that is in instances where a provider came into contact with someone who then forced that provider into a situation where they needed to quarantine, telehealth is a meaningful way to continue to stay in the game, so to speak, right? You continue to either consult with your peers and or even potentially consult with patients, provided you feel okay. Despite that fact that you're, physically having to be quarantined. And so there are lots of ways that we saw telehealth and telemedicine be applied in creative ways to extend capacity.
As a health system leader, what recommendations do you have for other health system leaders who are looking to invest in virtual care?
Yeah, I think something to keep in mind is that as your organization moves forward in the digital health journey, and if their goal is to really vastly change the way medicine is practiced broadly, I would encourage you to enter in strategic relationships with whichever telemedicine vendor seems to speak to the culture of your organization. Healthcare systems do not have digital health technology as a strength. Frequently, they don't have the relationships or sales channels established that they need to be highly successful in digital health. So I think creating a proper set of strategic relationships with vendors and digital health partners in the areas that you need the most help with are crucial to success.
How payers and health plans are adjusting to the rise of virtual care. How has Optum had to adjust its strategies in response to COVID-19?
Yeah, so I'll give you a few examples. So we moved literally, millions of visits online via telehealth, virtual, and other mechanisms. So we had a dramatic shift to telehealth, virtual, digital care. It significantly accelerated our care in the home visits. We already were doing over 2 million nurse visits to the home a year. We are now doing a lot of these through telehealth or other means. We're also making major investments, not just at hospital discharge, but how can you provide in-home primary care to people? So major shifts in our business. The other example I'd call out that a lot of people don't know about, states started running into problems with COVID testing, where they were, how are we going to test for COVID for our entire state's population? Optum Serve, one of our businesses, and also MedExpress provided support, is doing COVID testing where we've done over 1 million COVID tests since the start. So we are likely one of the biggest, if not the biggest, sort of care service delivery mechanism for COVID testing. So for example, we're doing COVID testing for the whole state of California, including mobile testing, where we'll go where the state needs COVID testing to be performed, and then feed that data back into the state system. So we've stepped up in a lot of different ways. We're doing that for large employers now, where we'll do COVID testing and return to work if they need to go back to work for some reason. For example, in the entertainment industry, we're working with a very large employer so that those employees can go back to work in a safe way. And so we provide a whole package of services for return to work for large employers. So we've made some pretty significant adjustments to COVID and also enabling states, large employers, and others to deal with the crisis.
How will the rise of virtual care affect the quality of patient care?
Yeah, so I'm optimistic that with telemedicine that it can be integrated in a way that drives better quality. I'll give a couple examples. The collaborative care model in mental and behavioral health, when I was at CMS, we actually tested that through the Innovation Center, and then we expanded that into Medicare, so it became anyone in America could be paid for the collaborative care model, which is essentially, primary care clinicians communicating with psychiatrists or other behavioral health specialists to manage care for people with mental and behavioral health conditions. So, and that's enabled by telehealth. So direct payment mechanism for telehealth with clear outcomes that are measured. So better quality, lower costs, once again. I think as we deploy telehealth in Optum, we're focused on doing it in a value-based way. How does it drive better quality, lower cost? How do we measure that? Traditionally people thought of telehealth as, it's going to be a replacement visit for, an ear infection or some other common ailment. That's still possible. It can still do that. But I think telehealth can do so much more. I think what it's going to be most effective in the future is how do you integrate telehealth and virtual care with in-person care so that, a Medicare beneficiary with 7 chronic conditions, you're able to manage them throughout the course of a year, keep them out of the hospital, keep them out of the emergency room because you're focused on maintaining their health, mostly in their home, but also when needed with in-person visits.
Blue Cross Blue Shield of North Carolina was one of the first organizations to pay telehealth at parity, which was one of your first initiatives to expand access to virtual care during the pandemic. How did you make this decision?
The decision was basically me pounding my hand on the table and saying, we're doing this. So the first case of COVID was announced in North Carolina, diagnosed in North Carolina, I believe on March 6th, and we announced our policy within 24 hours of that. The pandemic just dramatically changed our calculus, and all of the hand-wringing that we had done, and we probably would have gotten there over time, but it would have taken us a couple of years if there had not been a pandemic. But suddenly the priority became and remains keeping people out of the delivery system that don't need to go in for a face-to-face visit for their provider. And so it just put a whole new lens on how we thought about virtual care. And we got there pretty quickly. I think most people don't maybe don't understand that it is challenging. And so any commercial payer is actually a coalition of different subscribers and different payers or purchasers. So we have large group accounts, we have individual market, small group market, we have Medicare Advantage. Each of those has a distinct financing system, distinct set of regulations. And so, it's not as simple as pounding the table and say we're doing something, but you have to very quickly navigate that thicket of contract and regulation to get to the right answer.
How do you think COVID-19 has changed the relationship between payers and providers?
Yeah, so we have seen some acceleration of the uptake of our value-based model. We call our value model Blue Premier, and we're proud, and I believe that we have tried to turn North Carolina into a model kitchen for the rest of the country and push the envelope in value faster and harder than any other payer. We have pushed even harder during the pandemic, and the two things that I have observed are, we have played an important role in stabilizing revenue for primary care providers, and so giving them stabilizing payments, provided that they are a part of our value program. And so we call it Accelerate to Value, that program, and giving them a bridge that helps them survive and make it through this time, but then being part of a longer term partnership with us. I also see, and I think this is the future that I alluded to, a greater and greater willingness to do more radical things like primary care capitation. And I think that I don't wish for any of us that we had to live through all of this and still have to live through this, but it does unlock a different type of imagination about the future. And I think I'm very hopeful about what primary care delivery could look like, 1 or 2 or 3 years from now.
What are 3 key takeaways from your experience at Blue Cross North Carolina over the last 6 months?
I think that there are some fundamental things about healthcare and the way we pay for healthcare. For much of healthcare, fee-for-service is just a terrible way to pay for care long-term and finance care. We actually need for a certain amount of capacity to exist in the healthcare system. And we're paying for that capacity to be there in our time of need. And unfortunately, we finance healthcare in a way that compels hospitals to run it as close to 100% capacity as possible. And where when the volume drops, it jeopardizes their financial stability, and this is even more acutely true for primary care. And so I think we need to be deeply reflective and thoughtful about the underlying financial structure for healthcare and how we pay the providers. And I would just say, related to that, I've been so moved by providers, even in financial distress, that have kept their doors open and continued to see patients, even at personal risk to themselves. So there's true heroism in the practice of medicine and professionalism. The last thing I'd say is that we, like many payers, have waived cost sharing for COVID-related diagnosis and treatment, which I think was the right thing to do and important. And we were one of the first to do that. But it raises the question, if you do it for COVID, why can't you do it, or why shouldn't you do it for other diseases? Philosophically, I don't have an answer to that, and but the funding for healthcare all comes from the same place, and so one of the ways in which we have offset the rate of growth of healthcare cost and premium growth is over time by shifting more and more of the burden for paying for healthcare to patients. And we are not different from other payers in the country in the way we've done that. I don't think that's the right long-term direction for our healthcare system and for healthcare financing. And I think, focusing on this idea that in a crisis we chose to waive cost sharing for a specific disease, it really illuminates the broader problem with subjecting patients to such high levels of cost sharing. And that's the third thing that I would say requires deeper reflection.
Employer innovations, redesigning benefit offerings during a global health crisis. How are employers responding to the COVID-19 pandemic and the recession?
Well, employers are already focusing on digital healthcare and their strategies over the past 5 or 6 years. And this summer has really highlighted the need to be committed to those programs. But not just because of the pandemic, but because of just convenience and the cost of care. About 70% of employers revealed in a survey this summer that they were offering telemedicine at a reduced cost for their employees. And maybe 5 or 10% of employers were completely waiving the cost of access to telemedicine. And I think that's going to continue in the future. I think employers and employees are really realizing the value of these programs. And so they're going to find ways to incent people to really use them by making them easier to access, a cheaper form of care than an urgent care center or an in-person facility. What's interesting to see this summer is the number of employers that are picking up programs pretty much off cycle. So employers have been adding digital remote care programs such as MSK and behavioral health and diabetes programs faster than they would have in a normal course of dealing with their strategy. So employers are taking a more proactive look at their healthcare strategy. They can't let insurance brokers and health plans dictate how they're going to design something and what they're going to offer to their employees. Progressive employers are realizing they need to shape how healthcare is delivered in this country. They need to engage their employees and their families in finding the best source of care, and often that's remote digital therapies. But I think what's also new, employers are realizing that they can't just keep adding costs to their employees. They can't keep making their employees pay for more things. We have to buy healthcare differently. So for many years, 20 years, employers have been focused on the demand side of things. We've been controlling healthcare costs by making our employees pay more, by cost sharing and other actions like that. Now it's time for employers to step back and say, I'm going to buy healthcare differently and focus on the supply side of healthcare. I know that the supply side is the most broken part of healthcare, not necessarily the demand piece. So we need to bring better sources of care to our employees and their families.
How has telemedicine offerings for employers evolved over time?
We're seeing a trend with the old traditional brick and mortar type facilities where they're embracing telemedicine, first out of necessity through the crisis, but also just in general, and the diversity of offerings. Historically, if you go back 5-6 years ago, most of the telemedicine clients that we had were really just primary care, urgent care focused. And now there's just so many tremendous specialties. And VertaHealth's a great example with a singular focus and just doing tremendous things to help type 2 diabetics basically have a better life and better outcomes. I think there's a challenge for telemedicine companies in trying to fight for the attention of the decision makers on the payer side and at the employer side. And it seems to me that there's an opportunity for the creation of a network. And I envision like a wagon wheel type approach with perhaps a primary care provider of telemedicine services in the center and then the various spokes being those single specialty providers that focus on whether it be chronic disease management or behavioral health or women's health, men's health, and of course there'll be a host of new things coming out, substance abuse, and literally creating a network. So instead of all of those individual providers trying to chase down the benefits director of Boeing, all of a sudden you've got a nice network that you can provide to them, because only a portion of their employee population are going to need the services of some of those single specialty providers. So it could be a very attractive way to present the entire group of organizations. So it becomes kind of a one-stop solution.
Have you considered how the cost of telemedicine will adjust post-pandemic?
What we're beginning to find is that people are settling back into what they're used to. Something that we're also beginning to see, adding fees to the telehealth side of the equation, such that it's looking much more like it's a volume versus a value proposition. And what we want to be careful of is that if we're going to go in and sell telehealth as a cost reduction strategy, which many healthcare organizations, of course, they're viewing it that way, and other organizations across all industries, right, are viewing it that way in their partnership with these health systems. What we need to be very careful to do is not begin to tag those with additional costs that's just going to sit us back right where we are right now. So I think that there needs to be some real thought about monetizing every single element of the telehealth process such that, we're going to pay those visits the same as we would an in-person visit. That's a very, very slippery slope that we need to be very thoughtful about.
How can employers mitigate risk by shifting to a value-based care strategy?
First of all, employers should be developing a system of virtual care that supports employees through this resumption of healthcare. But this should be combined with steerage to value-based models of healthcare delivery. Value-based care has never been more relevant. Providers who are reimbursed through more capitated models are the ones who were best positioned to survive because they had a steady stream of revenue over, the last 6 months. Unlike those providers that have been so focused on these, higher margin elective procedures that in a pure volume-based business model, when all of that has come to a stop. So I guess I would just encourage employers to feel emboldened to continue the momentum towards value-based care that was really starting to take hold pre-pandemic and has come to much of a halt as far as employer focus in recent months.
How can payers and employers support patients through the pandemic?
Well, I think the first thing we saw is the loosening up of telehealth and remote healthcare so that people could continue to get their care needs met through virtual environments. I mean, we socialize, we do so many things today in virtual environments, and healthcare seems to be the last one to the dance. And again, a lot of what we've done in digital care and telemedicine has had to be built on the financial backbone of fee-for-service. And I don't think those two really work well together. And I would hope that payers and employers would be more aggressive, not just in the pandemic, but going forward, to create these kind of environments and to look for delivery systems in primary care that can really embrace these tool sets, telemedicine, so that consumer can get their questions answered and build a stronger relationship with their primary care team and their care management team in a way that, again, meets them where they are. It would be a lost opportunity, in my view, to go back to the kinds of go sit in the doctor's office and wait to be seen when we could just restructure the nature of the primary care payment system. It's where we spend the least amount of money anyway. So if we're going to start to restructure, that's the place to do it.
the patient community, what we're looking forward to. What changes are patient communities most excited to see?
U.S. healthcare has been fragmented and disjointed for years and decades. COVID-19 has put that in technicolor. The COVID-19 pandemic has helped us focus on the need and opportunity for creating a new system that enables people to be healthy, a system that is proactive rather than reactive. We'd love to see more virtual care be front and center. This seems like what the Virta Health Clinic has been doing all along, and we've been able to learn so much from Virta and from the patients who are lucky enough to be part of this system. DQ&A talks to about 18,000 patients every quarter in nearly 10 countries, and they have really come back and said thousands of patients are loving virtual care. We know that there are many things to improve still in virtual care, but we want more listening to what people are responding to. Let's be more data-driven and fact-based about what's working for patients and about what is working in the system. Moving toward a person-centered system that puts the people first and the condition second, that is where we're going. Once we can make that shift in our system, in our country, once we can make that shift in our narrative, then we can move toward greater overall health and well-being. One silver lining in this epidemic has been the ability for different organizations, diatribe.org is one, Virta is another. We've been able to bring many more groups of people together. That's reduced hierarchy, that's prompted creativity. We have loved the melding of much more communication among many different groups. And we would love to see more of that communication. We absolutely can do it. We need to do it in unison, singing from the same songbook. It is absolutely vital for us to be moving forward in synchronicity, developing a songbook, developing more playbooks, working together, deciding on narratives and deciding on actions. Thank you so much, Virta, for making so much of this possible.